Okay, I can open the PPT. So anyway, so very good morning, dear doctors. The FMGE exam is over. I think as per the exam analysis, this year FMGE exam was little more repeats as I felt from the OBG aspect of view. Okay, here there is a set of around 25 to 30 OBG questions with the proper clinical scenarios. Okay, doctors, I'm going to start this session. So now, before going to this session, actually 2 days back I got one FMGE MCQ discussion. In that discussion, around 3 to 4 topics as discussed in detail, especially primary amenorrhea, contraception, primary amenorrhea, CA cervix, and antepartum hemorrhage, that is abruption placental. So usually questions from those 3 topics has appeared in this year exam. I think that discussion would have been helped you for your exam. Okay, doctors, now we will start the session. Now, first of all, I am going to take the two important questions. One from most potential topic of gynecology, that is primary amenorrhea. Okay, look into the question here, dear doctors. A mother brings her 18-year-old daughter to the gynecology OPD with a complaint that she has not started having menses with normal levels of LH and FSH. So now the brother brings her 18-year-old daughter that she not attained MRKH, and so age is the 18-year-old. Next, general examination reveals normally developed breast and pubic hair. Here, dear doctors, here if you see the question, it's a crystal clear question and it's a repeat question. Here secondary sexual characteristics are present. Here breast and pubic hair is present. On pelvic examination, vaginal ending is blind and uterus is not palpable. So which is the most likely diagnosis? Yes, it's a repeat question which was asked many times in FMG, not only in FMG, many central exams this question was repeated. So now this year also this FMG June 2021 this question was repeated. Now dear doctors, before going to the question, just I want to discuss few more things related to primary amenorrhea. So dear doctors, primary amenorrhea is the most highly potential topic from the aspect of any exam. If you take any exam, FMGE, IUCD, NEET, PG, whatever may be the exam, you are going to expect minimum 2 to 3 questions from this topic. So that's why I want to take this topic in detail in a very simple box. Now, dear doctors, first of all, we know the definition of primary amenorrhea. Recently, there is a change in the definition of primary amenorrhea. What is that? It is in the absence of secondary sexual characteristics, no menses till 13 years of age, or in the presence of secondary sexual characteristics, no menses till 15 years of age. This was a recent change in the definition of primary amenorrhea. Please, I want everyone to make down this change. So when you take secondary sexual characteristics as a criteria, no menses till 15 years, or if you won't take secondary sexual characteristics as a criteria, no menses till 13 years of age. That is the one thing. Okay. So now before going to the actual topic of primary amenorrhea, now the definition of primary amenorrhea, just we'll discuss the phenotypic differentiation of male and female fetus. How the phenotype of male and female fetus will appear. Look, if you take male fetus, you all know gonads is the testis. Gonads is the testis, and you know whenever the testis is there, the karyotype will be 46XY. 46XY. Okay, so now, dear doctors, look into here, 2 lining cells of testes are Sertoli cells and Leydig cells. You know, Sertoli cells produces anti-Mullerian hormone or Mullerian inhibiting hormone. Anti-Mullerian hormone or Mullerian inhibiting hormone means whenever functioning Sertoli cells are there, means there will be AMH production. Whenever AMH production is there, automatically this AMH won't allow Mullerian structures to develop. So that is no uterus, no cervix, no upper two-third vagina. Understood? This point is clear. Okay. So whenever functional sertoli cells are there will be production of AMH. There will be production of AMH or MIH, that is Mullerian inhibiting hormone or anti-Mullerian. Means it won't allow Mullerian structures to develop. That's why there is no uterus, no cervix, no upper two-third vagina. And you all know, so lower one-third vagina develops from urogenital sinus. Develops from urogenital sinus. Yes, yes. Next, the second lining of cell is Leydig cells. You all know this Leydig cells produces androgen, that is testosterone. Now this testosterone is converted to dihydrotestosterone. So that is one androgen is converted into another androgen. That is testosterone is converted into DHT by the enzyme 5-alpha reductase. Dear doctors, whenever this DHT present in the fetus, the phenotype, the external genitalia is always male. That was the take home message. For male phenotype, DHT should be present in the fetus. For male phenotype, DHT should be present in the fetus. That is a final take home message. Yes, yes. So this is about the phenotypic differentiation of male fetus. Now come back to the phenotypic differentiation of female fetus. Doctor, if you look into here, so female fetus, you all know gonads is ovary, that is 46XX. Now, you all know two important lining cells of testes is sertoli and Leydig. When gonads comes as a ovary, there will be no sertoli and no Leydig. No sertoli means no AMH or no MIH. No AMH or no MIH. Whenever there is no AMH or no MIH, automatically Mullerian structures will be present. Yes, uterus will be there. Uterus will be there. Cervix will be there. And upper two-third vagina will be there. Yes, because we are discussing the female fetus. We are discussing female fetus. Yes, yes. And whenever there is no Leydig cells, means no testosterone. So no testosterone means no DHT. Yes, whenever DHT is present in a fetus, phenotype will always be male. Whenever DHT is absent, dear doctor, it is always female phenotype. Female phenotype. Yes, yes. Dear doctors, here is important take-home messages. Whenever functioning sertoli cells is present, whenever functioning sertoli cells is there, so they will release AMH or MIH. Automatically there will be no Mullerian structures. And non-functioning sertoli cells means whenever there is streaked testes or whenever there is a ovaries. So whenever streaked testes or streak ovaries, so what happens? There will be no AMH or no MIH. That's why Mullerian structures will be present. Mullerian structures will be present. I think you have to remember, doctor, whenever DHT is present, it is always male phenotype. When DHT is absent, it is always female phenotype. Whenever sertoli cells are present, Mullerian structures will be absent. And important one-liners. Many times you people will confuse these two important one-liners. You people appears as a controversy. Dear doctor, first sign of puberty is always, doctor, it is the first sign of puberty is growth spurt. First sign of puberty is growth spurt. First visible sign of puberty is telarg. First visible sign of puberty is telarg. So telarg is nothing but appearance of breast budding. Appearance of breast budding. Yes? Yes. Okay, doctors. Now, before coming to this question, we'll go to the compartmental classification. Dear doctor, if you see this compartmental classification, so look into this. Here, the outflow tract. Dear doctor, the outflow tract, which is the compartment 1. So, what was the outflow tract? Uterus, cervix, vagina, and hymen. Uterus, cervix, vagina, and hymen. That is compartment 1. And compartment 2 is ovary. Compartment 3 is anterior pituitary. And compartment 4 is hypothalamus. You know, this hypothalamus releases GnRH, which acts on anterior pituitary to release LH and FSH. which releases LH and FSH. Now this LH and FSH acts in ovary to release estrogen and progesterone. Dear doctors, now this estrogen has got negative feedback effect on GnRH, and even progesterone has also got negative feedback effect on GnRH. Okay, so both of them, both estrogen and progesterone, which is released from the ovary, have got negative feedback effect on GnRH, which is released from the hypothalamus. Yes, yes. Now with this compartmental classification, now it goes to the, if the some pathology affects different compartments, what will be the hormonal profile? Okay, if you know the hormonal profile, you can understand which compartment is defect. You got the point? If you know the hormonal profile, you can understand which compartment is defect. Now, dear doctors, come to the compartment 2. You all know compartment 2 is, dear doctors, compartment 2 is ovary. Whenever ovary is pathology, or whenever the ovary is, dear doctors, defective, whenever the ovary is defective, what happens? So what happens to estrogen and progesterone? Decreases. Estrogen and progesterone decreases. When estrogen and progesterone decreases, what happens to GnRH? Negative feedback effect to GnRH will be lost and GnRH level will increase. When GnRH level will increase, automatically LH and FSH level will increase. Here gonadotrophic levels are high. That's why it is hypergonadotrophic. You got the point here. Gonadotrophic levels or hormones are high. That's why hypergonadotrophic and hypogonadism. Please make a note of it. I think this is crystal clear. So whenever the pathology involves compartment 2, so there is no estrogen or no progesterone, negative feedback effect to GnRH will be lost. So automatically GnRH will increase and LH/FSH will increase. So it is hypergonadotrophic hypogonadism. Now come to compartment 3 or compartment 4. Compartment 3 is anterior pituitary and compartment 4 is hypothalamus. Now dear doctors, something happens to compartment 3 or compartment 4. So GnRH level will decrease. When GnRH level will decrease, LH and FSH level will decrease. When LH/FSH level decreases, estrogen and progesterone level decreases. Here gonadotrophic hormones are low. That's why it is hypogonadotrophic. Please make a note of it. Hypogonadotrophic hypogonadism. Hypogonadotrophic hypogonadism. Yes, yes. Now come to compartment 1, that is uterus, cervix, vagina and even hymen. Some pathology involves uterus, cervix, vagina or hymen. What happens to hormonal profile? Everything will be normal. Everything will be normal. That's why compartment 1 pathology is eugonadotrophic. Please make a note of it. Eugonadotrophic, eugonadism. What I'm telling these points is, if you know the hormonal profile, you can come to the which compartment is defect, and you can go to the disorders which involve that compartment. Yes, yes. So is it clear? Compartment 2 is hypergonadotrophic hypogonadism. Compartment 3 and compartment 4 is hypogonadotrophic hypogonadism, and compartment 1 is eugonadotrophic eugonadism. Please memorize these things. It will help you to solve so many questions, because this concept not only important in primary amenorrhea, it is also important in solving questions in infertility, many of the topics. Yes, yes. Okay, doctors. Now with this knowledge, we'll go to few things related to the secondary sexual characteristics. Now, doctors, you all know we have two important secondary sexual characteristics. One is breast, another one is height, another one is axillary aid and pubic aid. Here, doctor, for the breast and height to develop, estrogen is required, and for axillary and pubic aid to develop, androgens are required. Androgens are required. And for estrogen and androgens to release, gonads should be functioning. Gonads should be functioning. Please, this is a take-home message. Whenever gonads are not functioning, you can't expect secondary sexual characteristics. So gonads means either it could be an ovary or either it could be a testis. Both. So gonads can be ovary or testis. If ovary or testis are not functioning, dear doctors, please make a note of it. You can't expect secondary sexual characteristics. Means indirectly in gonadal dysgenesis. Means gonadal dysgenesis means which compartment, dear doctor? I think it's the compartment 2. In gonadal dysgenesis, what happens? Secondary sexual characteristics will be absent. Please take home message. In gonadal dysgenesis, dear doctors, in gonadal dysgenesis, secondary sexual characteristics will be absent. Yes, yes. And the scoring system for secondary sexual characteristics is Tanner's scoring or Tanner's staging. Tanner's scoring or Tanner's staging. Tanner's scoring or Tanner's staging. Yes, yes. Okay, doctors. So we'll go to the actual topic proper of this primary amenorrhea. Now, doctor, looking at this, in each primary amenorrhea condition, please try to know these 5 points. One is karyotype and one is gonads. Yes, if you know the karyotype, we can tell that gonads. That is, if it is testis, it is 46X5. If it is ovary, it is 46XX. And phenotype, yes. For male phenotype, what is required? I told you, DHT should be required. For female phenotype, DHT should be absent or DHT should be insensitive. Okay. And for secondary sexual characteristics, whether present or absent. And for uterus, whether present or absent. Dear doctor, please memorize these 5 points in each primary amenorrhea condition. What point? Memorize these 5 points in each primary amenorrhea condition. So karyotype, if it is XX, yes, gonads will be ovary. If it is X5, it is gonads is testis. And for male phenotype, I told you DHT should be required. For male phenotype, DHT is required. And for secondary sexual characteristics to develop, what is required? I told you gonads will be required. Gonads will be required. And for uterus to develop, what is required? So sertoli cells, that is, sertoli cell should not be there. Because if sertoli cell should not be there is no image, uterus will be present. Yes, these 5 things should be known in each primary amenorrhea condition. Yes, yes. Okay, doctors. Now, come back to the compartmental classification. Dear doctors, for the time being, we will discuss 2 important disorders in compartment 1 and compartment 2. Yes. For the time sake of you, we will discuss 2 important disorders in each compartment, that is compartment 1 and compartment 2. Dear doctors, in compartment 1, we have got important condition, that is MRKH. MRKH. Please make a note of it. So now we have got 2 important. So we have got 2 important conditions in each compartment, that is compartment 1 and compartment 2. In compartment 1, dear doctors, we have got 1 condition, that is MRKH, and another 1 condition, androgen insensitivity syndrome or testicular feminization syndrome. These are the 2 disorders which is related to compartment 1. And compartment 2, that is gonads, that is gonadal dysgenesis. Gonadal dysgenesis. Okay. So here we have got 2 disorders. One is Turner's. Yes. Another one is Swires. Okay, doctors, we will discuss these 2 topics. Okay. So now look into this. Now, so this is about the 2 important disorders in each compartment, that is compartment 1 and compartment 2. Okay, so in compartment 1 we have got MRKH, that is Mayer-Rokitansky-Kuster syndrome, and another 1 condition, androgen insensitivity syndrome or testicular feminization syndrome. In compartment 2, that is gonadal dysgenesis, we have got Turner's and Swires. Okay, now first we will take the MRKH, that is Mayer-Rokitansky-Kuster syndrome, that is Mullerian agenesis, which is a component of MRKH. Now here, doctors, I told you in each primary amenorrhea condition you should know the karyotype. If you know the karyotype, you can know the gonads. Yes, if you know the gonads, automatically karyotype can be given. And whether secondary sexual characteristics present or absent. For secondary sexual characteristic to occur, gonads should be functioning. Yes, and whether what happens, this uterus present or absent, and phenotype. Now you notice karyotype here is 46XX. When XX is a karyotype, the gonads will be ovary. So ovary means it is functioning ovary. Please make a note of it. It is functioning ovary. So whenever this functioning ovary means, what is the function of ovary? That is ovulation. Whenever ovulation is possible, dear doctors, estrogen and progesterone can be produced. And whenever estrogen and progesterone are released, secondary sexual characteristics will be present. I told you, whenever gonads are functioning, yes, secondary sexual characteristics will be present. Whenever gonads are not functioning, secondary sexual characteristics will be absent. Here gonads are functioning, so ovulation will be there, yes. So ovulation will be there, so estrogen and progesterone will be there, secondary sexual characteristics will be present. And the word itself says Mullerian agenesis. Okay, doctor, the sound is clear, audio is clear. Some of them are telling the audio is clear. Yes, yes. Okay, doctors, the word itself says Mullerian agenesis, means there is no Mullerian structures. Means, dear doctors, so no uterus, yes, no cervix, and no upper two-third vagina. No upper two-third vagina. Yes, yes. So Mullerian agenesis means Mullerian structures will undergo agenesis. So that's why there is no uterus, no cervix, no upper two-third vagina. Yes, and what about lower one-third vagina? Yes, lower one-third vagina will be present. Why? Because lower one-third vagina develops from urogenital sinus. Due to lower urogenital sinus is normal here, that's why it will contribute to lower one-third vagina. That's why it will end in blind vagina. Vagina will be ending in blind. That's why blind vaginal pouch. Blind vaginal pouch. Yes, yes. And investigation of choice for MRKH is USG. And treatment is vaginoplasty. Name of the vaginoplasty will be Mackondoi vaginoplasty. Mackondoi vaginoplasty. Yes, yes. So finally, 46XX karyotype, gonads is a ovary, that is functioning gonads. So secondary sexual characteristic will be present and uterus will be absent. It is Mullerian agenesis. Mullerian agenesis. Yes, yes. Okay, doctors. So next condition. So now you can come back to this cryptomenorrhea. Dear doctors, before going to this cryptomenorrhea, look into this just simple language how this amenorrhea will be divided. Doctor, amenorrhea, we have got two varieties of amenorrhea. One is primary, another one is secondary. This primary can be true primary amenorrhea or false. False, that is pseudo primary amenorrhea. Okay, doctor, in this false or pseudo primary amenorrhea, what is that? They will have cyclical symptoms of menstruation. Means monthly they will have got pain, but the bleeding is not revealed outside. That is without external bleeding. That is they got cyclical pain abdomen. They got cyclical pain abdomen, but the bleeding is not revealed. So what is the diagnosis? Cryptomenorrhea. Cryptomenorrhea. And what is the two important BDs for cryptomenorrhea? One is imperforate hymen. Yes. Another one is transverse vaginal septum. Transverse vaginal septum. Yes. Yes. Okay, doctors. Most common differential diagnosis or most common cause for cryptomenorrhea is imperforate hymen. The question which has appeared in the recent June FMGE exam. Yes, yes. Okay, doctors. So cryptomenorrhea, most common cause for imperforate hymen is the most common cause for cryptomenorrhea. Now come back to this cryptomenorrhea, dear doctors. Cryptomenorrhia, I told you two important differential diagnoses. One is imperforate hymen. One is imperforate hymen. Okay. So one is imperforate hymen, another one is transverse vaginal septum. Transverse vaginal septum. Yes, yes. Transverse vaginal septum. Okay, doctors. Now look into this. Okay, sir. Now look into this. Now See, cryptomenorrhea, two important differential diagnoses. One is the imperforate hymen, another one is transverse vaginal septum. Here, there will be the either imperforate hymen or either there will be transverse vaginal septum. But there will be cyclical shedding of endometrium. There will be cyclical shedding of endometrium. Means there will be ovulation. Due to ovulation, there will be cyclical shedding of endometrium. Due to the cyclical shedding, blood will collect in the vagina. What is it called as? Emetocolpus. Can also collect in the cervix. That is emetocervix. Or even can also collect in the uterus. That is emetometra. Emetometra. Yes? Yes. So, okay, doctors. Now, what is the clinical presentation? Yeah, there's a cyclical shedding of the endometrium, but the bleeding is not revealed outside. That's why clinical presentation, dear doctors, clinical presentation is primary amenorrhea. Clinical presentation is primary amenorrhea. And automatically gonads will be what? Ovary. Gonads will be ovary. That's why it is functioning. So, secondary sexual characteristic will be present. Secondary sexual characteristic will be present. And doctor, due to emetocolpus, the patient can have urinary symptoms. Secondary to pressure effect by emetocolpus. Secondary to what? Pressure effect by emetocolpus, she can have urinary symptoms. And if you see the local examination, especially in imperforate hymen, we can see bluish bulging membrane. Bluish bulging membrane. Yes, yes. Especially in imperforate hymen. Especially in imperforate hymen. And treatment for imperforate hymen, that is cruciate incision and drying the collected blood. Cruciate incision and drying the collected blood. Yes? Yes. Okay, doctors, I think this is clear. The question asked is cruciate incision, and another the question asked in the yesterday's, day before yesterday's FMGE exam is regarding the Mullerian agencies. Yes? Yes. So come back to the first question, dear doctors. Come back to the first question. So now looking at this here, LH and FSH will be normal. Hormonal profile will be normal. Which compartment? Compartment 1 pathology. Yes. And secondary sexual characteristics will be present. Yes. Yes. And blind vagina. Because blind vagina means it is lower 1/3 vagina is present. Lower 1/3 vagina. And uterus is absent. What is the most likely diagnosis for this scenario? MRKH. MRKH. I think this is clear. I think this is clear. Just a few points on Turner syndrome and testicular feminization syndrome. Turner syndrome is compartment 2 pathology, and testicular feminization syndrome compartment 1 pathology. Here gonads are normal. Yes. What is the pathology? We look into these few points on testicular feminization syndrome or androgen insensitivity syndrome. Okay. Now look into this. Doctors, later we can come back to this. So, androgen insensitivity syndrome or testicular feminization syndrome. Doctor, here the gonads are functioning. Yes. But what is the pathology? Yeah, here gonads, that is testis, that is the 46XY. 46XY. Testis means what, doctor? It is a 46XY. When gonads are functioning, what is the pathology? Here, the pathology is lies with androgen receptor pathology. Androgen receptor pathology. Yes? Yes. So, gonads are functioning. Androgens are produced, but androgens can't act due to androgen receptor insensitivity. That's why it is called as androgen insensitivity syndrome. Yes? Yes. Now, here the gonads are functioning is functioning testis. You know, functioning testis means functioning sexually. So, functioning sexually means AMH will be released or MIH will be released. Due to AMH or MIH, Mullerian structures will be absent. Mullerian structures will be absent. That's why there is no uterus, no cervix, and no upper 2/3 vagina. No upper 2/3 vagina. Yes? Yes. And whenever functioning testis is present, functioning lady. So whenever functioning lady, what is important function of ladies is androgen production, that is testosterone. Now the testosterone is converted into dihydrotestosterone. Yes? Yes. But this dihydrotestosterone can't act. Why? Due to androgen receptor insensitivity. Due to androgen receptor insensitivity, there is androgen production, but androgens can't act. That's why when androgens can't act, phenotype will be female, but internally gonads will be testes, but phenotype will be female. That's why it is testicular feminization syndrome. Testicular feminization syndrome. Yes, so in androgen insensitivity syndrome or testicular feminization syndrome, it is a XY gonads but female phenotype. Regarding the secondary sexual characteristics, I told you it is a functioning testis. That's why functioning ladies. I told you, no, functioning ladies. Whenever functioning ladies are present, androgens are produced. These androgens can't act. Yes, these androgens can't act. Why can't act, doctor? That is receptor insensitivity. Receptor insensitivity. When androgens can't act, no axillary or no pubic hair. You got the point, dear doctors? No axillary and no pubic hair. Now more androgens, that is more androgens is converted to estrogen, produces breast. Means androgen insensitivity syndrome patients will have secondary sexual characteristics. What secondary sexual characteristics? Only breast. Yes. No axillary or pubic hair. Please make a note of it. This is important take-home message. No axillary or pubic hair. Okay, doctors? So no axillary or pubic hair. I think this is clear. So 46XY gonads, that is functioning gonads. That's why secondary sexual characteristic will be present. What secondary sexual characteristic? It is only breast but not axillary or pubic hair. Yes? Yes. Why? Because it is due to receptor insensitivity. Okay, doctors? So now come back to the important flowchart. Whenever a patient comes to gynecology with a history of primary amenorrhea, so you should always examine for secondary sexual characteristics. So if secondary sexual characteristics are present, means gonads are function indirectly. When secondary sexual characteristics are present, always the next investigation is TVS. Why you will do TVS? To rule out whether uterus present or absent. Whether uterus present or absent. When uterus absent, I told you two important differential diagnoses. One is MRKH, another one is androgen insensitivity syndrome or testicular feminization syndrome. And dear doctors, whenever uterus is present, still there is no bleeding. Means what happens? That is, they have got cyclical endometrial shedding, but the bleeding is not revealed. What is that? Cryptomenorrhea. And most common differential diagnosis for cryptomenorrhea is imperforate hymen. Most common differential diagnosis is imperforate hymen. Yes, yes. And MRKH, dear doctor, 46XX, 46XY. And ovary testis. Yes, yes. And secondary sexual characteristic is present. Clinical presentation is primary amenorrhea. So here we got both breast and axillary and pubic hair. Here only breast, only breast, only breast. Yes, yes. I think you have studied about both compartment 1 pathology, that is Mullane and agenesis, and androgen insensitivity syndrome or testicular feminization syndrome. I think this is clear for you all. And few points on compartment 2 pathology. Doctor, I told you compartment 2 pathology is what? Gonads, that is gonadal dysgenesis. Turner's is the female gonadal dysgenesis and Swires is the male gonadal dysgenesis. And Turner, I told you 45XO. Turner, just a minute. So Turner's is a 45XO. Yes. So in our gonadal dysgenesis, there is no secondary sexual characteristics. Secondary sexual characteristic will be what, doctor? Absent. Why, doctor? Why secondary sexual characteristic? Streak ovary means no ovulation. No ovulation. No ovulation. And Mullane structures will be present, but it is infantile. Why infantile? due to estrogen deficiency. Due to estrogen deficiency. Because no ovulation means what? No estrogen. No ovulation means no estrogen. So that's why due to estrogen deficiency, infantile structures are present, but infantile. And phenotype, it is always female. Phenotype, it is always female. Yes? Yes. And another important male gonadal dysgenesis, that's why it is 46XY. That's why streak testis. Streak testis means there is no functioning sertoli and no functioning leg. No functioning sertoli means no AMH or no MIH. No AMH or no MH, Mullane structures will be what? Present. Mullane structures will be present. Yet no functioning ladies means no testosterone. So no testosterone means no estrogen. Secondary sexual characteristics will be what? Absent. Secondary sexual characteristic will be what? Absent. Yes? Yes. So this is about compartment 2 pathology, that is Turner's female gonadal dysgenesis and what? Swyer's male gonadal dysgenesis. And final take home message, any condition with XY karyotype. What are the conditions with XY karyotype? One is testicular feminization syndrome or androgen insensitivity syndrome, and another one Swyer's syndrome. Swyer's syndrome. These two conditions, they are XY karyotype, that is 46XY karyotype. In these conditions, dear doctor, gonadectomy should be the first line management. Gonadectomy should be the first line management. I think, dear doctors, the primary amenorrhea topic, especially compartment 1 and compartment 2 conditions are clear now. So in compartment 1, Mullane agenesis, that is MRKH, and another one, it is testicular feminization syndrome or androgen insensitivity syndrome. And compartment 2, Turner syndrome or Swyer's. And doctor, whenever gonads are functioning, secondary sexual characteristics will be present. Yes, yes. Whenever sertoli cells are functioning, yes, Mullerian structures will be absent. Mullerian structures will be absent. Whenever DHT is present, always male phenotype. Whenever DHT is absent, always it is female phenotype. Female phenotype. And whenever any condition with XY karyotype, gonadectomy should be the first line management. I think this is clear. Now, dear doctors, one question regarding the primary amenorrhea we have discussed. The next question, final take home message is, doctor, whenever secondary sexual characteristics are absent and uterus present, secondary sexual characteristics are absent means most of the time it will be gonadal dysgenesis. So 45XO means Turner's and 46XY means Swyer's. At least remember this. At least, if you are not able to remember full description of primary amenorrhea, at least remember this dictum. Whenever secondary sexual characteristics present means what? It is gonadal dysgenesis. When uterus present and secondary sexual characteristic absent, sorry doctors, when secondary sexual characteristics absent and uterus present, if it is 45XO, Turner's and 46XY, Swyer's. When secondary sexual characteristics present and uterus absent, 46XX, it is MRKH, and 46XY, it is androgen insensitivity syndrome or testicular feminization syndrome. Yes? Yes. Now we see the second question on the primary amenorrhea, which was asked in the recent FMGE June 2021. A 16-year-old girl visits endocrinology clinic with complaint of primary amenorrhea. Yes, chief complaint is primary amenorrhea. Secondary sexual characteristic is present. Yes, secondary sexual characteristic is present, and there is bluish. We can see bluish bulging membrane. Yes, dear doctor, we can see this bluish bulging membrane. Yes. What is this diagnosis, dear doctors? What is this diagnosis? Yes, it is imperforate hymen. Imperforate hymen. Whenever imperforate hymen is there, what is the treatment they ask? I can look. So what is the treatment? What is the best treatment for this condition? The diagnosis is imperforate hymen. Answer for this question is cruciate incision and drainage of collected blood. Yes, as I told you, primary amenorrhea is ideal topic. So we have discussed two questions. Now we will go to the next question. Dear doctors, you can see a 28-year-old paraben leaving one was inserted copper key 2 years ago and attends the clinic for a routine checkup. On examination, on post-speculum examination, threads of the IUCD are not found. Threads of the IUCD are not found. And abdominopelvic X-ray shows below image. This was the image. And what is the next step in the removal of property, or what is the ideal management? Here, if you see this image, the property is, yes, missed. Your property is missed. So now the topic of today's in the contraception topic is missed IUCD. How do you manage missed IUCD? Now looking at this, dear doctors, we have got the option. One is hysteroscopy, another one is wait and watch, another one IUCD OOC and laparoscopy. Now dear doctors, we have got these choices. We'll come back to the discussion. Doctor, if IUCD is missed, what all the options can be possible? If IUCD is missed, what happens? One, thread is detached and fallen. Yes, one option can be IUCD can be that the IUCD thread can be detached or fallen, or IUCD is perforated. IUCD is perforated, or thread is coiled inside. Thread is coiled inside. Or what happens? The IUCD is expelled out. These are all the options possible when you won't see thread on first speculum. One, the thread is detached and fallen, or IUCD can be perforated, or thread is coiled inside, or IUCD is expelled. So expulsion is diagnosis of exclusion, which can be proved. That is, neither the IUCD is seen in X-ray or AOSG. Yes. Whatever may be these scenarios, always the first investigation is USG. Yes. Always the first investigation is USG. Please search the device first inside the uterine cavity. If you won't see the IUCD inside, then proceed further. So first investigation is always transvaginal soluble. And what is the next investigation? Doctor, if you won't see IUCD inside the uterus, then proceed further. What is the next investigation? Next investigation is X-ray. X-ray with uterine sound or with new IUCD. Yes. So you do the X-ray with uterine sound or with new IUCD. This uterine sound or new IUCD will guide the position of old IUCD. That's why we'll do X-ray with uterine sound or new IUCD. Still, we are not able to identify the position of IUCD. The last investigation is laparotomy. Yes, first investigation is TVS, next investigation is X-ray, and third investigation, that is last investigation, is laparotomy. Yes. Now we do the management of this missed IUCD. If you see the IUCD inside the uterus, we can go for hysteroscopic removal. If you see the IUCD outside the uterus, that is in the abdominal cavity, you can go for laparotomy. Usually, IUCD is a foreign body. It will form adhesions inside the abdominal cavity. That's why laparoscopy is less feasible. Because due to adhesions, it's very difficult to remove the IUCD with laparoscopy. Yes. So if it is inside uterus, go for hysteroscopy. If it is perforated, go for laparotomy. Yes. Now come back to the question, dear doctors. So if you see the image, here the IUCD is perforated. Yes. Now, what is the answer for this? Usually if IUCD is perforated, we have to go for laparotomy. Most suitable option for this question is laparoscopy. Yes, I think this question is clear. So you can take down all these points that will help you in the future exams. Yes. False statement regarding MVA syringe. Doctor, this is an MVA syringe, manual vacuum aspiration syringe. Yes, any syringe, if it is menstrual regulation syringe or manual vacuum syringe, you should know about the pressure. Yes, you should know about the volume. Until anomalies, it is recommended for MTP. Yes. Now, the manual vacuum aspiration syringe, look into this. It can be up to the pressure or vacuum required is 650 mm mercury, and the volume is 7 65 ml and up to 12 weeks. Doctor, up to 12 weeks we can use this MVA for MTP. You got the point? So these are the golden points, dear doctors. So 1/6 pressure, the vacuum pressure is, dear doctor, the vacuum pressure is 650 mm mercury, volume is 65 ml, and up to 12 weeks we can recommend this MVA syringe for MTP. And the wrong option here, the first statement is volume of 30 ml. Yes, doctor, please, this was a wrong option. This was a wrong option. Yes, this is a true statement. Yes, this is a true statement, and this is also a true statement. Yes, yes. Okay, doctor. Next question. Yes. Here is a wonderful question. A 24-year-old woman visits labor casualty at 37 weeks. So she is 37 weeks period of gestation and mild labor pains for 10 hours. And cervix is 1 centimeter dilated but not effaced. Labor pains for 10 hours, 36 weeks, 1 centimeter dilated and non-effaced cervix. Doctor, here the two differential diagnoses. One, it is false labor pains. Either it could be a false labor pains or either it could be a prolonged latent phase. Yes, these are the two important differential diagnoses. One is false labor pains and prolonged latent phase. Dear doctors, false labor pains and prolonged latent phase are going to differentiate by therapeutic rest. Doctor, please make a note of that. I told you, 36 weeks gestation, labor pains for 10 hours and cervix 1 centimeter dilated and cervix not effaced. So two differential diagnoses I told you, false labor pains, yes, and another one is what? What, doctor? Prolonged latent phase. Prolonged latent phase. Doctor, how will you differentiate? By sedation or by therapeutic rest, by either giving sedation with morphine. Doctor, if patient with false labor pains will subside, and patient with prolonged latent phase, pains will continue and they will have cervical changes. You got the point? This is how you differentiate between false labor pains and prolonged labor pains. Just you give analgesia or sedation and you should know if labor pains subsides, it is false labor. If labor pains continues to be present, it is prolonged latent phase. And what is the answer for this question, dear doctor? What is the answer for this question? It is sedation and wait. Doctor, this is a repeat question which was asked 2 to 3 times in the central exam. This was a repeat question which was asked 2 to 3 times in the central exam. Yes? Yes. Okay, doctors, now. Yes. This was one question from the miscarriage. So, 26-year-old, gravid 3 female with history of 3 previous mid-trimester abortion, that is second trimester abortion, yes, present at 22 weeks of gestation with cervical length of 20 mm. What could be the possible cause for her previous 3 miscarriage? And so she has got 3 previous miscarriage which occurs at mid-trimester, that is second trimester. What could be the most common cause? Now looking to this, you have to remember these 4 victims regarding the miscarriage one-liners. Please, I want everyone to take down this. It's a high yield potential point. But the most common cause for first or second trimester spontaneous miscarriage is the chromosomal abnormalities. Chromosomal abnormalities is the most common cause for first or second trimester spontaneous miscarriage. And most specific chromosomal abnormality is monosomy X. Even I quoted the reference of Williams Obstetrics 25th edition, page number 347. So monosomy X, that is Turner syndrome. Monosomy X is nothing but Turner's. And most common chromosomal abnormality is trisomy, that is either trisomy 13, 16, 18, 21 and 22. These are all the most common. That is, most common chromosomal will be trisomy, most specific chromosomal will be monosomy. And most common cause for mid-trimester abortion, it is always anatomical cause. Anatomical cause. What is that anatomical cause, doctor? Cervix incompetence. Cervix incompetence. Yes? Yes. So, first and second trimester spontaneous miscarriage is chromosomal abnormality. Spontaneous miscarriage is chromosomal abnormality. Most common chromosomal abnormality will be trisomy, most specific will be monosomy, and most common cause for mid-trimester abortion. Yes, this is a mid-trimester abortion. Cervical incompetence is the most suitable option. Yes, yes. Okay, doctor. Okay, now, so we will go back to the next question. Yes. So this is a wonderful question which was asked in cardiac disease complicating pregnancy. Here, a 28-year-old woman, dear doctors, 28-year-old woman with prosthetic valve who is on warfarin become pregnant. What advice will be given to the mother in this pregnancy? Doctor, this was also a repeat question which was asked in AIMS. Most of the questions are repeats. Most of the questions are repeats. Yes, doctor. So she was a prosthetic heart valve patient. Now was an orphan. Now she became positive. So what advice will be given to this patient regarding the thromboprophylaxis? Doctor, you all know up to 12 weeks. Yeah, doctor, up to 12 weeks we used to give unfractionated heparin. Up to 12 weeks we used to give unfractionated heparin. From 12 to 36 weeks it is warfarin. Why not warfarin in first trimester? Due to warfarin embryopathy. Please make a note of it. Here no warfarin, because what, doctor? It affects the embryogenesis. Yes, so up to 12 weeks you give heparin. From 12 to 36 weeks you give warfarin. Once again you stop heparin. Yes, you stop warfarin at 36 weeks. This was the exam question in the IUCD or AIMS. At 36 weeks you switch over from warfarin to heparin. Please make a note of it. This was also $1 million MCQ. At 36 weeks, switch over from warfarin to heparin. And for 6 hours after vaginal delivery and 24 hours after cesarean, please you restart both heparin and warfarin. So take home message here is first trimester only heparin, no warfarin. And at 36 weeks switch over to heparin from warfarin. That is a take home message. Yes? Yes. Okay, doctors, now look into this. So here she is first trimester. She is in first trimester. Was on warfarin, who become pregnant, and she is a prosthetic heart valve patient. So you replace warfarin with heparin. Yes, yes. Now you come back to the 8th question. Doctor, look into this. A pregnant woman presents for a routine antenatal checkup at 18 weeks. Okay. On abdominal examination, uterine size found to be 16 weeks. That is, dear doctor, fundal height is less than the period of gestation. She says 18 weeks, but fundal height shows only 16 weeks. What are the differential diagnosis? One, wrong dates. One could be the wrong dates. Another, it could be what? Oligohydramnios. Yes. And another one, it could be IUGR or intrauterine fetal demise, or it can be transverse line. Yes, even in transverse line also the fundal height will be less than the PUG. Here most feasible diagnosis is what? So here the patient, yes, on USG oligohydramnios was found. Yes, in the question itself they have given USG shows oligohydramnios. Which of the following is likely cause? Doctor, you all know she is 18 weeks. Oligohydramnios in early pregnancy most of the times will be associated with anomalies, like renal anomalies. Yes, so now, usually the answer for this question is renal agenesis. Yes, yes. So now, dear doctors, if oligohydramnios and polyhydramnios, few one-liners here. So doctor, what is the cutoff for maximum vertical pocket or single deepest pocket? Maximum vertical pocket or single deepest pocket less than 2 centimeters. Yes, oligohydramnios will be called. A5 less than 5 centimeters. Yes, oligohydramnios. Yes. Now, maximum vertical pocket or single deepest pocket for polyhydramnios is more than 8 centimeters or amniotic fluid index more than 24 centimeters. Yes, yes. Doctor, please make a note of it. These are all the $1 million MCQs. So maximum vertical pocket or single deepest pocket less than 2 cm is oligohydramnios, more than 8 cm is polyhydramnios. AFI less than 5 cm is oligohydramnios, and AFI more than 24 cm is polyhydramnios. And most common cause for mild oligohydramnios is idiopathic. And most common cause for severe oligohydramnios, I told you, congenital anomalies, especially renal anomalies, that is renal agenesis. Yes. Here, okay, just I will switch on the power and I will come back. So mild oligohydramnios, idiopathic, yes. Severe oligohydramnios, yes. Renal anomalies. I told you, so you can come back to answer for this question is renal agenesis. And here, doctor, if you suspect oligohydramnios in early pregnancy, what happens? There is less space. Yes, it results in fetal anomaly. Most common will be pulmonary hypoplasia. You got the point, doctor? If you suspect oligohydramnios in early pregnancy, what happens, doctor? So in early pregnancy, less space will be available for the growth of the fetus. So results in fetal anomalies. So what is the most common fetal anomaly? Will be what? Pulmonary hypoplasia. If you suspect oligohydramnios late in pregnancy, organogenesis is already completed. So no problem associated with fetal anomalies. It will result to what? It leads to cord compression. Yes. Yes or no? Less amniotic fluid, cord gets compressed, results in meconium passage. Which results in meconium aspiration syndrome. Yes. So I think few things we have discussed related to oligohydramnios also. Now, doctor, I think which is the most effective and cheap cervical cancer screening test? I think this was a question which was asked in the CS service. Doctor, which is the most effective also and cheap cervical cancer screening test? Doctor, among the screening tests, we have got pap smear. Yes. We have got liquid-based cytology. That is LBC. We have got VIA. What is VIA? Visual inspection acetic acid. Yes, that is 3 to 5% acetic acid, and villi, that is visual inspection Lugol's iodine, and HPV DNA testing. Dear doctors, please make a note of it. These are all the screening tests which done in asymptomatic patients. So one is pap smear, liquid-based cytology, VIA. What is VIA? So visual inspection acetic acid, 3 to 5%, and villi, visual inspection Lugol's iodine, and HPV DNA testing. And diagnostic tests, biopsy, yes, colposcopy. These are all the diagnostic tests. Colposcopy and conization. These are all the diagnostic tests. Among this, the cost-effective, more cheap, which can be done in mass screening is pap smear. Cost-effective, most cheap, which can be done in mass screening is pap smear. Answer for this question is pap smear. And sensitivity of pap smear is 57%. And doctor, co-testing, you should know this. Co-testing means pap plus HPV DNA testing. And sensitivity of co-testing is 100%. But cheap, most effective, cost-effective will be pap smear. Yes. And identify the image. Dear doctors, you all know it's a simple question. It's a pedunculated submucosal. Yes, doctor. In this image, instead of asking like this, they can ask you what FIGO classification this fibroid comes. Yes, doctor. FIGO classification of fibroid is high-yield MCQ for all exams. Understood? No? So just I wrote an image here, doctor. I told you this is a pedunculated submucosal. Yes. So now looking to this. Doctor, so look into this, what's the image? Doctor, look into this. First, we'll look into submucosal. What is zero? Yes, zero is pedunculated. Here, doctor, zero is what? Peduncle is there. Doctor, look into this. Zero is peduncle is there. So that is zero is pedunculated submucosal. Doctor, this is the Fibo classification. And what is one? One is, doctor, it is submucosal only, but less than 50% intramural. Yes. Less than 50% of the fibroid is intramural. Less than 50% of the fibroid is intramural. And two, this is submucosal only. More than or equal to 50% is intramural. Yes, within the myometrium. See, doctor, this is a pedunculated submucosal, and this is, doctor, some part of the fibroid is entering the mural intramural. That is less than 50%. This is more than or equal to 50%. Submucosal only, this one will be less than 50% intramural and more than or equal to 50% intramural. And coming to others, 3 is contact. Yes, there is a contact. This fibroid contacts the endometrium. That's why contact endometrium, but 100% intramural. 100%. And regarding the 4, this is a 4. It is intramural but not contacting the endometrium. Intramural but not contacting the endometrium. And 5, dear doctor, and 5, it is what, doctor? More than or equal to 50%. Yes, can see more than or equal to 50% intramural. More than or equal to 50% inside the myometrium. And 6, less than 50% intramural. Less than 50% intramural. And 7, dear doctor, it is a pedunculated subserosal. 7, pedunculated subserosal. Okay, doctor, pedunculated subserosal. Please try to memorize the Fibo classification. Submucosal 0 is pedunculated and less than 50% is intramural. More than or equal to 50% intramural but submucosal. And when you come to others, 3 is contact endometrium, 4 is intramural, 5 is more than or equal to 50% intramural. Yes, and it is less than 50%. See, this is the less than 50%. This is more than or equal to 50% and pedunculated subserosal. And if you see this 2 to 5, there is a connection from submucous to subserosal. There is the fiber extends from submucous to subserosal, that is called as hybrid leiomyomas. So we will give 2 numbers. Each number will be separated from hyphen. So each number will be separated from hyphen. What is it called as hybrid leiomyomas? That is 2 numbers separated by hyphen. First refers to relation with endometrium and second refers to relationship with serosal. This is the first. The 2 refers to relation with endometrium and 5 refers to relation with serosal. That is called as hybrid leiomyomas. That is called as hybrid leiomyomas. Yes. So here it is pedunculated submucosal. As per Figo, it is submucosal 0. If you tell as per Figo classification, it is submucosal 0. Yes. Okay, doctors. Next. Okay, doctors. So I think this is clear. Now, if you see this image, identify the image. But if you see this, here there is anterolateral vagina. The site is, doctor, the site is anterolateral vagina. And doctor, so what are all the swellings or what are all the anterolateral vaginal swellings? You usually will have what? So anterolateral vaginal swellings usually you will what, doctor? So I told Bartholin cyst. Yes, Bartholin cyst. Most common will be Bartholin cyst. Understood? And some other swellings will be like cystocele, Gardner's cyst. How do you differentiate all these, doctor? If you see the Bartholin cyst or Gardner's cyst, there is no cough impulse. Yes, no cough impulse. But if you see cystocele, yes, if you cough, there will be increase in the size of the cystocele. Cough impulse will be positive. Cough impulse will be positive. But there is no cough impulse in Gardner's cyst and Bartholin cyst. But Bartholin cyst, yes, usually anterolateral aspects of the vagina. And here the image suits for what? Bartholin cyst. Image suits for Bartholin cyst. Yes. Okay, doctors. Now, here another question from carcinoma cervix. A 15-year-old woman was found to have carcinoma cervix figo staging 3B. What would be the management? Yes, stage 3B. What is the management? Doctor, you have to remember 3 dictums for CA cervix management. Yes. First dictum, all stages is radio sensitive. Dear doctor, all stages of CA cervix, please make a note of it. All stages of CA cervix is radio sensitive, but before giving radiation, chemo agent is given making cells receptive for radiation. What is it called as? Chemo radiation. Means first we will give 3 to 6 cycles of chemotherapy. First we will give 3 to 6 cycles of chemotherapy, so that this chemotherapy makes tumor cells receptive for radiation, followed by radiotherapy. First we will give chemotherapy, then radiotherapy. What is it called as? Chemoradiation. And what is that radiosensitizer agent in CA cervix? Cisplatin. Yes, doctor. So chemoradiation we can give all stages. Initially we will give 3 to 6 cycles of chemoradiation, followed by radiotherapy. What is the radiosensitizer in CA cervix? What is the radiosensitizer in CA cervix? Cisplatin. Until stage, dear doctor, look into this till stage. Sorry. One minute. Just till stage one minute. Here, doctors, just I will come back to that question. Sorry for inconvenience. Okay, doctors, till stage 2A1 we can do surgery. Till stage 2A1 we can do surgery, and any stage with tumor size more than 4 centimeters. What are all the stages with tumor size more than 4 centimeters? 1 stage 1B3 and 2A2. Always chemoradiation. Doctor, always chemoradiation. Please make a note of it. This is clear. Okay, doctor. So till stage 2A1 we can do surgery, but all stages we can give chemoradiation, and any stage with tumor size more than 4 centimeters. What are all the stages with tumor size more than 4 centimeters? One stage, that is 1B3 and 2A2, always chemoradiation. No surgery should be preferred for tumor size more than 4 centimeters. Yes. So finally, stage 1 to stage 2A1, all stages we can give what? Chemoradiation. Means from stage 1 to stage 2A1 we can give chemoradiation also, we can do surgery also. But stage 2A2 to stage 4, only chemoradiation. Yes, I think this is clear. Okay, doctor. So finally you have to remember these 3 dictums. All stages is radiosensitive, but before giving radiation, chemo agent is given making cells receptive for radiation. What is it called as? Chemoradiation. So what is the chemoradiation called as? That is 3 to 6 cycles of chemotherapy. 3 to 6 cycles of chemotherapy, followed by radiotherapy. So what is that radiosensitizer? Cisplatin. What is that radiosensitizer? Cisplatin. Until stage 2A1 we can do surgery. Means till stage 2A1 we can give chemoradiation also and surgery also. But after 2A1 only chemoradiation, no surgery. That's all. That is a final take-home message. Now, a nursing staff was conducting a delivery for a primary gravida in labor OT. Following delivery, nurse by mistake given oxytocin IV bolus. Doctor, you all know oxytocin never given IV bolus. I think this is common usual message, never given IV bolus, because it causes sudden hypotension. Yes. So that is a take-home message. Everyone knows answer is sudden hypotension. It is not hypertension or hyperglycemia or hypoglycemia. It causes sudden hypotension. And doctor, has a FMGE or NEET PG as well, you should know the list of uterotonics. List of uterotonic. Please make a note of it. Here is the list of uterotonic. First line will be oxytocin, that is 10 units IM or IV infusion. 10 units IM or IV infusion, and never IV bolus. I told you why never IV bolus. It causes sudden hypotension. It causes sudden hypotension. And maximum, doctor, maximum dose we can give 40 units. Maximum dose we can give 40 units in 1 pint RL or 500 ml of oil. Yes, yes. And what about ergot alkaloids, ergometrin or methyl ergometrin? Doctor, we usually give 0.2 mg IM or IV. This is start dose. Doctor, start dose 0.2 mg IM or IV, and maximum dose 0.2 mg every 4 hours for 5 doses. Every 4 hours for 5 doses, that is totally 1 mg. 1 mg. So maximum dose of ergot alkaloids, start dose is 0.2 mg IM or IV. Maximum dose is 0.2 mg every 4 hours for 5 doses, that is 1 mg. And prostaglandins, we have got 2 important prostaglandins. One is carboprost and misoprostol. Carboprost PGF2 alpha, start dose is 250 microgram intramuscular. Maximum dose 8 doses. 8 doses means 8 into 250, that is 2000 microgram or 2 mg. Up to 2 mg we can give maximum dose of carboprost. Start dose is 250 microgram IM, maximum dose is 8 doses, that is 2000 microgram or 2 mg. And misoprostol, dear doctor, for prevention 600 microgram, and for treatment, dear doctor, for treatment it is 800 microgram. Please take down. So these are all the $1 million MCQs. So doctors, so misoprostol for prevention it is a 600 microgram. For treatment it is 800 microgram sublingually or orally. Sublingually or orally. Yes. And symptometry, one of the other drugs, symptometry is a combination of oxytocin plus ergometry. Oxytocin plus ergometry. Oxytocin is 5 units, yes, and ergometrin is 0.5 mg. Ergometrin is 0.5 mg. So please make a note of that. Okay. So symptometrin is a combination of oxytocin plus ergometrin. Oxytocin is 5 units and ergometrin is 0.5 mg. And carbetocin, doctor, it is single dose 100 microgram intravenous injection. 100 microgram intravenous injection. And tranexamic acid, it is 1 gram IV infusion. Doctor, please, you should know about the list of uterotonics. First line will be oxytocin, second line will be ergot alkaloids, and third line will be prostaglandins. And other drugs, symptometrin, carbetocin, and tranexamic acid. That is 1 gram IV infusion. Next. Look, it's a simple graph. It's a simple topic from the menstrual cycle. Which of the following peak is responsible for ovulation to occur? Doctor, you all know just before ovulation, LH surge should be required. That is, I don't require any explanation. If at all, you can look into our videos regarding the menstrual cycle. LH surge is mainly responsible for ovulation to occur. See, this is the ovulation. Just before ovulation, it could be the LH surge. So which curve represents LH? It is a C curve. C curve. That is option C. It's a simple logic. And so it's a repeat question. This was also asked in the one of the Central Institute exam aims. Okay. So for ovulation to occur, LH surge is required. You got it? So before ovulation, LH surge is required. For ovulation, both LH and FSH surge is required. You should be crystal clear. Before ovulation, dear doctor, please take down. Before ovulation, what is required? LH surge occurs. LH surge occurs. For ovulation to happen, yes, for ovulation to happen, first FSH surge, then followed by LH surge. Then followed by LH surge. It's a simple logic. Yes. So before ovulation, what is the surge? LH surge. What is the curve? Curve C. Now if you come back to curve A, only in luteal phase. Curve A, only in luteal phase, means what it is? Progesterone. Yes, yes. And if you come, doctor, if you come to the curve B, yes, you can see just before ovulation there is a peak, and then there is in luteal phase also there is a peak. What is that? It is B is estrogen. B is estrogen. And the curve D, dear doctor, curve D is FSH. FSH. And C is LH. Doctor, this graph is repeated so many times. Please clear. Okay, doctor. So progesterone is a curve A, and estrogen is a curve B. LH serves as a curve C. FSH serves as a curve D. Yes? Yes. Okay. Now, I think this is a simple question. 25-year-old paragon living one delivered 12 weeks back, attains labor casualty with complaints of continuous heavy bleeding. She also gives history of DNC in some private hospital, but still she continues to bleed. What could be the reason for this bleeding? Dear doctor, so normal menses is very unlikely to occur by 12 weeks postpartum. Yes, this is ruled out. DNC is an acute event. Yes, it is not a chronic event. Till it will wait 12 weeks to occur. No, it is an acute event. DAC is very, very unlikely. And there is no any preceding event for DAC here, like abruption and all. Understood? No? And here you can suspect PPH. But why not? PPH is very, very unlikely because she gives history of DNC in some private hospital, but still continues to bleed. They have done DNC for retail products. To remove the retail products also, if you would have done retail products, they have done DNC and they remove the retail products. Now PPH is also very, very unlikely. And here, dear doctor, following delivery, still 12 weeks, till 4 weeks, with 3 months, 3 to 4 months of continuous bleeding, very, very likely to have gestational trophoblastic news. Very, very likely to have gestational trophoblastic news. Understood? Normal menses, yes, it is very unlikely to have normal menses by 12 weeks postpartum. DAC is an acute event, yes, usually occurs immediately after delivery, not wait up to 12 weeks. And PPH, it could be a secondary PPH, but she has undergone DNC in by DNC or removed retained products. Very likely choice for this question is gestational trophoblastic neoplasia. Yes, yes. Okay, doctors. Here, 23-year-old gravida 1 presents to a physician at 19 weeks gestation with no significant medical history. State that diabetes runs in her family. ECG is normal. Urine analysis shows urine analysis is negative for proteinuria, and laboratory study shows LBS more than 126 and HbA1c level. HbA1c level is more than 6.5%. Likely diagnosis. Okay, as a NEET PG aspirant, you should know the diagnostic criteria for pre-gestational diabetes mellitus and gestational diabetes mellitus. Here is the diagnostic criteria. Dear doctor, here is the diagnostic criteria for pre-gestational diabetes mellitus or overt diabetes mellitus. FBA should be more than 126 mg/cent for pre-gestational diabetes, and here FBA should be more than 92, more than or equal to 92 mg/cent. Please make a note of it. More than or equal to 92 mg/cent, but less than 126 mg/cent. Please make a note of it. FBS more than or equal to 126, it is pre-GDM. More than or equal to 92, but less than 126, it is GDM. GDM. Yes, and 2-hour plasma glucose level should be more than or equal to 200 mg/cent. 2-hour plasma glucose after 75 gram glucose load should be more than or equal to 200, and RPS more than or equal to 200, and HbA1c more than or equal to 6.5%. Please make a note of it. These are all the $1 million MCQ. Okay, doctors, whenever it is 200, close your eyes and go for overt diabetes. And whenever FBS more than or equal to 126, yes, it is overt diabetes or pre-gestation. And doctor, this is the DIPSI cutoff. Yes, DIPSI cutoff. Yes, as a NEET PG aspirant or FMGE aspirant, you should know about the DIPSI cutoff. DIPSI cutoff. Yes, whenever 200, it is overt diabetes or pre-gestation. And HbA1c, it is glycosylated hemoglobin. Glycosylated hemoglobin. Okay, doctor? Glycosylated hemoglobin. And FBS more than or equal to 126, yes, it is pre-gestation. And 2-hour plasma glucose after 75 gram glucose load, it is DIPSI. Whenever DIPSI or RBS 200, always over diabetes. Okay, there are a few lines on diabetes. Sorry, DIPSI, that is diabetes in pregnancy. Please take note, diabetes in pregnancy. Study group of India. Please make a note of it. Is ideal potential MCQ. That's why just few lines on DIPSI. Now what is this DIPSI? Just non-fasting. Will give 75 gram glucose load. Then we will measure plasma glucose at 2 hours. Non-fasting 75 gram glucose load. 2 hour cutoff should be more than or equal to 140 milligram percent for diagnosis of GE. Understood? So irrespective of our need, just you give 75 gram glucose load and measure plasma glucose at 2 hours. It should be more than or equal to 140 milligram percent for diagnosis of GE. This defeats both screening and diagnostic. Yes. This is a correct statement. Yes, doctor. Some of them will always think it is only screening. No, it is both screening and diagnostic. That's why it is OGTT. OGTT. And DIPSI recommendations on OGTT cutoff values. I told you, will give 75 gram glucose load and measure 2 hours. If it is more than or equal to 200, what is diagnosed? Over diabetes. Over diabetes or pre-GDM. If it is more than or equal to 140, yes, it is GDM. More than or equal to 200, it is pre-GDM, pre-gestational diabetes. More than or equal to 140, GDM. More than or equal to 140, GDM. And yes, now come back to the question. Doctor, come back here. FBS is 126 and HbA1c was 6.5. Here the diagnosis is, I told you, FBS more than or equal to 126. Yes, pre-gestational diabetes mellitus. Yes, yes. I think this is clear now. Yes, doctor, this is a wonderful question. This is also a repeat question. Doctor, out of 25 to 30 questions, around 20 questions are repeat questions in the recent FMGE June exam. A 24-year-old woman attends gynecopedy with history of secondary amenorrhea, and she also gives history of preceding DNC for abortion, and her FSH is 6 international units. Doctor, normal FSH is 5 to 20 international unit per liter. Doctor, if you imagine, go back to the compartmental classification. Compartment 1, it is normogonadotrophy. Yes. Compartment 2, hypergonadotrophy. Compartment 3 and 4, hypogonadotrophy. Means in compartment 1, doctor, if you imagine, in compartment 1, normal FSH levels. Yes. In compartment 2, hypergonadotrophic, high FSH levels. Hypergonadotrophic, hypogonad. And compartment 3 and 4, it is low FSH. If you imagine your FSH is how much? Your FSH is how much? 6. So 6 means it is normal. So which compartment is defective here? Yes, it is uterus, compartment 1. Either it could be uterus, cervix, or vagina. Whatever it could be. Compartment 1 pathology. So ovary is read out. Yes. Prolactin, that is pituitary. Compartment 3, yes, that is also below. Sheehan syndrome, pituitary, yes, that is also below. Only left is Asherman syndrome. What is Asherman syndrome? It is intrauterine synetia. Yes. You know, it's a simple logic. You identify which compartment. Here FSH is normal. So normal FSH is compartment 1. High FSH is compartment 2. Low FSH is compartment 3 and 4. So here it is hyperprolactinemia very unlikely because pituitary problem FSH will always be low. Ovarian failure compartment 2 FSH will be always high. Sheehan syndrome compartment 3 FSH will be low. So these 3 is ruled out and left out is Asherman syndrome. And most common risk factor. Dear doctors, most common risk factor for Asherman syndrome. Asherman syndrome is, doctor, DNC, dilatation and curettage. Dilatation and curettage. Dilatation and curettage. Yes? Yes. Most common risk factor for Asherman syndrome is dilatation and curettage. Here, the patient gives history of DNC. Yes, that is a catchy point. And Asherman syndrome is nothing but what? Intrauterine synetia. Intrauterine synetia. Compartment 1. Yes. So Asherman syndrome is more and more likely for this question. Yes. Yes. Okay, doctors. Now, I think this is a simple question. Which of the following structure is removed in hysterectomy? So you can close your eyes and tick fallopian tube because we won't remove ovary or omentum in case of hysterectomy. Yes. Yes. Okay, doctors. Yes. Now, a woman. Yes, even I discussed this question in the OBG MCQ for FMGE exam. You can look into that session also, live session. Okay, so a woman at 8 months of pregnant attends labor casualty with a history of pain and bleeding per vagina. That's painful vaginal bleeding and loss of fetal movements. On examination, uterus is tense, tender and rigid. Uterus is tense, tender and rigid. And fetal heart sounds are absent because she has got loss of fetal movements. And likely diagnosis is, here she has got painful vaginal bleeding, uterus is tense, tender, rigid, loss of fetal movements, FHS is absent. What is the diagnosis? And you can know by this step, you all know this. Option is what? Abruptio placenta. Option A is abruptio placenta. Now, few discuss this abruption. Look, abruption is nothing but premature separation of the placenta before onset of labor. Before onset of labor. So, placenta separates before onset of labor is abruption. We have got three varieties. One is the revealed variety, concealed variety and mixed variety. And most common variety is always revealed. Some book use mixed, it is not mixed, it is revealed. Okay, in the concealed, if you see, there is the blood accumulates behind the placenta, results in formation of retroplacental clots, that is RP clots. You got the point? Due to separation of the placenta, there will be blood accumulating behind the placenta. What is it called as? Retroplacental clots, RP clots. And sometimes the blood can seep through the fetal membranes and appears in the vagina. What is it called as? Revealed. And most common variety is revealed. Most common variety is revealed. Now we'll go to the clinical features. You all know this in the concealed variety, in concealed variety, there is retroplacental clot. This retroplacental clot releases thromboplastin and thrombin. Okay, you all know whenever thromboplastin is released, it causes pain. That's why abruption it is always, doctor, abruption it is always painful vaginal. Why? Due to release of thromboplastin from the RP clots, there is painful vaginal pain. Painful vaginal bleeding. Due to pain, uterus is tense, tender and rigid. Due to pain, uterus is tense, tender and rigid. And most of the times, the head will be fixed or engaged, not palatable like placenta previa. In placenta previa, the head is palatable because placenta is covering the os. Here, due to separation of the placenta, majority of the women will be in the labor. This thromboplastin induces labor pains. That's why, dear doctors, fetal head will be fixed and engaged. And due to separation of the placenta prematurely, there will be distress or even FHS will be absent. And fundal height will be more than POG, especially in concealed variety. Because the blood accumulates behind the placenta, makes the fundal height more than POG. Yes? So, doctor, there will be release of thromboplastin from the RP clot. This causes or induces pain, labor pain. That's why it is painful vaginal bleeding. And there will be tense, tender uterus, tense, tender, rigid uterus. Okay, doctor, there will be tense, tender, rigid uterus. And the head will be fixed or engaged. Why? Because it induces labor pains. And due to premature separation of the placenta, there will be distress or even FHS will be absent. And this RP clot also releases thrombin, which consumes clotting factor in abruption patient. That's why abruption patients are more prone for DIC, that is consumptive coagulopathy. Please make a note of it. That is consumptive coagulopathy. So RP clots releases thromboplastin, RP clots releases thrombin, which makes the patient to prone for DIC, that is consumptive coagulopathy. Yes, yes. And dear doctors, this is the RP class, that is the concealed variety. In this concealed variety, this blood can extravasate into the muscle layers of the uterus or even up to the serosum. Yes, even up to the serosal surface of the uterus, this blood can extravasate. What is that uterus called as? Covalent uterus. Covalent uterus. Usually seen in abruption, not placenta. Usually seen in abruption, not placenta. Yes? Yes. Doctor, please make a note of it. Especially in concealed variety, we will see this covalent uterus. Especially in concealed variety, we will see this covalent uterus. Yes? Yes. The few points differences in pain, placenta previa and abruption. Majority of the times they will ask you in the exam. Doctor, it is a painless bleeding. It is a painful bleeding. and it is bright red color, and this is a dark color. Due to painless, doctor, due to painless, uterus is soft and relaxed. Due to pain, uterus is tense, tender and rigid. And doctor, here fundal height corresponds to POG, here fundal height more than POG, especially in conceived pregnancy. And I told you, it is easily palatable because placenta, which is covering the os, prevents the fetal head entering the pelvis. But in abruption, due to thromboplastin, head enters pelvis. Means it is fixed and engaged. It is fixed and engaged. Painless, painful. Soft and relaxed, tense, tender, rigid. Equals to POG, more than or equal to POG in conceived. Easily palatable, fixed and engaged. And bleeding is always revealed in placenta previa and mostly revealed. Yes, doctor, mostly revealed, but sometimes conceived. Sometimes conceived. Please make a note of it. Bleeding mostly revealed in abruption, but sometimes conceived. And doctor, usually the placenta prevents the fetal head entering into the pelvis. That's why it is mobile. That's why mobile head is more prone for malpresentation. Yes, in placenta previa, malpresentations are always common. And diagnosis of placenta previa, yes, just transvaginal sonography. Just transvaginal sonography. And doctor, please make a note of it. Diagnosis of abruption, it is always clinical diagnosis. It is $1 million MCQ. Please make a note of it. Diagnosis of abruption, it is always clinical diagnosis. Clinical diagnosis. And diagnosis of placenta, just TVS is enough to diagnose the placenta previa. And I told you in abruption, due to release of thrombin from orbitas, there will be consumption of clotting factors, which results in DIC, but there is no features of DIC. And most common risk factor for abruption is hypertension. Yes, yes. Understand, doctor? Please, diagnosis of abruption is always clinical. Painful bleeding, tense, tender, rigid uterus. But it is painless bleeding, soft and relaxed. Yes, yes. Doctor, I told you, I think you can come back to the question. So, in a tense, tender, rigid, painful bleeding, FHS are the more likely abruption. Doctor, in active labor, FHS will be present, and uterus won't be tense, tender. There is intermittent relaxation. Contracts and retracts. Uterus contracts and retracts, not tense, tender, rigid. And uterine rupture, fundal height. Doctor, fundal height will be less than POG because the uterus is given away. That's why the fundal contour also can't be made out. Yes, yes. Okay, doctors, now. Okay, now I think a 55-year-old post-menopausal woman attends gynecopedy with history of chronic pelvic pain. There's an X-ray of this image. Here we can see some calcified mass. Doctor, if you see some calcified mass in the pelvis, most likely will be fibroid. So I'll go for fibroid. Let us see the options. Ovarian mass, very unlikely. Ovarian mass, very unlikely to have calcified. Calcified ovarian mass, that is usually dermoid. Calcified ovarian mass, usually dermoid. But doctor, you know, dermoid will be very unlikely in 55-year-old. Very unlikely in 55-year-old. Yes, cervical cancer is very unlikely. Calcified fibroid. Yes, this is an image of calcified fibroid. Yes, yes. Okay, doctors, calcified fibroid. And doctor, this was a repeat question. You all know when you are a pregnant mother on lithium, yes, she'll always more prone for Epstein anomaly. Answer for this question is Epstein anomaly. This was also a repeat question. Yes, yes. And here, doctors, infants conducts a delivery, and in immediate postpartum period, mother develops breathlessness, hypotension, tachycardia, and collapse. As it is a immediate postpartum collapse. Doctor, you all know, for immediate postpartum collapse, one, it could be PPH. Yes. Another one, amniotic fluid embolism. Yes. And another one, uterine inversion. These are the three important differential diagnoses for immediate postpartum collapse. One, PPH. Amniotic fluid embolism, uterine inversion. Here, doctor, on per vaginal examination, there is no excess bleeding. There is no excess bleeding, there is no mass. So, PPH is ruled out, uterine inversion is ruled out. And amniotic fluid embolism is very, very likely in this question. Yes, answer for this question is amniotic fluid embolism. Is it clear? So, three differential diagnoses for immediate postpartum prolapse. One is, dear doctors, PPH, another one is amniotic fluid embolism and uterine inversion. In this question, it is amniotic fluid embolism because on pervasive examination there is no excess bleeding. That's why it is amniotic fluid embolism. Yes, yes. A pregnant woman is bitten by rabies dog. Doctor, I think you all know when you are a pregnant mother bitten by rabies dog, we can give rabies vaccine. You all know that. Rabies vaccine can be given safely. In addition to rabies vaccine, we have to give immunoglobulin. Yes. So, rabies vaccine plus immunoglobulin, yes. Both vaccination and immunoglobulin. Yes. Doctor, you can see rabies vaccine is a killed vaccine which can be given safely in pregnancy. That's why, so when a pregnant mother is bitten by a rabies dog, please give both vaccine and immunoglobulin. Yes? Yes. Okay, doctor, which type of pelvis is associated with occipito-posterior position? Doctor, we have got four types of pelvis, which will include a few golden points in the four types of pelvis. Doctor, first is the gynecoid pelvis, which is the most common type of pelvis, and another one is android pelvis, which is a male type of pelvis. Doctor, you all know in gynecoid pelvis, the side walls are parallel. But in android pelvis, the side walls are convergent. Yes, convergent. Here in gynecoid pelvis, doctor, ischial spines are not prominent. But in android pelvis, ischial spines are prominent. And what is the obstetric outcome? This is a $1 million MCQ. Obstetric outcome, there is no delay in engagement. Yes, there is no delay in engagement in especially gynecoid pelvis. And most common position will be LOT or LOA. That is left occipito-transverse or left occipito-anterior. Here in android pelvis, yes, there is delay in engagement. And obstetric outcomes will be deep transverse arrest. Please take down, these are all the $1 million MCQ. Deep transverse arrest, that is DTA, or doctor, deep transverse arrest or DTA, or persistent occipito-posterior position. Yes, persistent OP. Okay, doctors, I think this is clear. Doctor, side walls will be convergent, ischial spines will be prominent, and engagement is delayed, and there will be deep transverse arrest or persistent OP position in android pelvis. And the next one is anthropoid, that is antero-posterior diameter is more than the transverse diameter, that is which is ape-like pelvis. Okay, doctor, here pelvic side walls are narrow. And ischial spines are not prominent. And obstetric outcome, dear doctor, occipito-posterior position is most common, especially direct occipito-posterior. Please make a note of it. Direct occipito-posterior position. Is most common. This was $1 million. So occipito-posterior means always anthropoid. Occipito-posterior means always anthropoid. And face to pubis delivery, doctor, face to pubis delivery, always anthropoid. Yes, always anthropoid. Okay, doctor. And platypenoid pelvis, that is transverse diameter is more than the AP diameter, which is the least common. And here, doctor, this is the only pelvis where side walls are divergent. Convergent side walls, android. Divergent side walls, platypenoid. Ischial spines prominent, android. Deep transverse arrest, android. Persistent occipito-posterior, android. Direct occipito-posterior, anthropoid. And obstetric outcome, dear doctor, one important obstetric outcome, engagement. engagement occurs by asynclitism. You can study in the, you can see the few videos regarding asynclitism. Asynclitism means platypulum. Asynclitism means platypulum. Yes, yes, I think this is clear. And this classification is Caldwell and Malloy's classification. Please make a note of it. Caldwell and Malloy's classification. Dr. Caldwell and Malloy's classification. This classification is given by Caldwell and Malloy's classification. Yes, yes. So I think so, doctor. So obstetric outcome in gynecoid is LUT or LOA. Obstetric outcome in android is deep transverse arrest or persistent occipito-posterior. Obstetric outcome in anthropoid is direct occipito-posterior and face-to-face. And here the question is occipito-posterior. Question is more common in anthropoid, especially anthropoid followed by android. Anthropoid followed by android. Yes, yes. Last question, dear doctor. Last question. Yes, doctor. It is a 26th question. So here a 24-year-old mother, primary gravida, attends AMC clinic with history of high BP, severe preeclampsia, that is 160, 112. Her laboratory study says elevated SGPT, yes, elevated LDH and low platelets. PT, APTT, serum fibrinogen are within normal and most likely dying. I think this is a simple question. Everyone would have been answered HELLP syndrome. Yes, here of course you all know HELLP syndrome. Doctor, make a note of it. HELLP syndrome, yes, it is hemolysis. That too, what type of hemolysis? Microangiopathic hemolysis. Microangiopathic hemolysis. Okay. Now that is the one thing, and another one, doctor, hemolysis. That's why LDH will be elevated. LDH is elevated due to microangiopathic hemolysis. And another one, doctor, L. This is H. EL is, doctor, elevated liver enzymes. Elevated liver enzymes. That is SGOT, SGPT. Yes, it is increased. And low platelet count. Low platelet count. So low platelet count, that is platelet less than 1 lakh. Less than 1 lakh. Yes, yes, these are the features of HELLP syndrome. Now, here we have got so many differential diagnoses. What are the differential diagnoses? Doctor, look into this. What are the differential diagnoses here in this question is? Doctor, just look into this. Just I'll have on page. So sorry. So here. So now look into this. Here, doctors, this HELLP syndrome, obstetric, cholestasis, and hepatitis. In all the four, doctor, in all the four, look into this. In all the four, there will be elevated LDH, yes, elevated SGPT and low platelet count. But here in obstetric cholestasis or HELLP syndrome or hepatitis, understood, no? So most of the time this PT, APTT and serum fibrinogen will be normal. Serum fibrinogen will be normal. Yes, yes. But among this obstetric cholestasis, HELLP syndrome, hepatitis, HELLP will be more likely. HELLP will be more likely in this session. Yes, understood. But regarding AFLP, don't look into this PT, APTT, it will be prolonged. Please make a note of. And serum fibrinogen will be reduced. Serum fibrinogen will be reduced. Please make a note of it. So, doctor, in acute fatty liver pregnancy, APTT and PT is prolonged and serum fibrinogen will be reduced. But in obstetric cholestasis, HELLP syndrome and hepatitis, PT, APTT, serum fibrinogen will be normal. And low platelet count and elevated LDH more will be seen in HELLP syndrome rather than obstetric cholestasis and hepatitis. That's why the question suits here for this is HELLP syndrome. Yes, yes. Okay, doctors. I'm going to end this recall session, and especially I took special interest on primary amenorrhea topic, and few topics I discussed in detail in this session because my final motto to teach you some few topics so that this session will help you in the future exams, and I made very simple clear regarding the primary amenorrhea. Yes, yes. Anyway, doctors, please, thank you. So give your valuable comments in this comment section. Thank you, doctors. All the best. God bless you all. Thank you.